So now, when you have a bleb that is failing, in its early stage, can we salvage this bleb? To talk about this, I invite Dr. Thomas George, who is a consultant in glaucoma at the Chaitanya Hospital in Trivandrum.
Thank you, Kiran. Bleb essentially is reservoir subconjunctivally for the aqueous draining out of the fistula we create during filtering surgery. The fistula should give us adequate resistance to maintain the IOP and keep the shape of the globe and the structures in place, but also allow for a flow to keep the intraocular pressure low enough. Tissues tend to heal up. So if the space is not maintained in the healing period, that's the immediate post-op, it will heal on to the episclera. Hence, a leak itself would cause the bleb to eventually fail. So if you've got a bleb leak, like Dr. Andrew has already shown you, near the limbus, a large diameter contact lens may help. And if it's not resolving in a couple of weeks, you need to resuture. And a buttonhole in the conjunctiva definitely needs to be resutured. And if the leak is close to the limbus, we would prefer to mobilize it to the limbus and suture it onto the limbus. If there's no bleb in the immediate post-op and there's no leak, we would go for a massage. We'd keep the bleb going with massage, either finger massage from below or right above the flap itself. And we would hold it with this conservative measure still about 2 weeks, because we want some amount of healing before we tamper with the sutures and increase the flow through the fistula. That is to release the releasable sutures or do a laser suture lysis, wait at least 2 weeks. In the meantime, we can use more of topical steroids and try to reduce the inflammation to slow down the scarring process. And if even after suture lysis or releases, the bleb is not forming and the IOP is not controlled, we need to plan on needling. Needling is for ideally a failing filter, though it will work for the failed filters if done much later also, but it works best for a failing filter. Timing should be at least 3 weeks post-op and can be up to 3 months to call it a failing filter in the sense that it's still not fully healed up. The procedure is to create a long subconjunctival tract and to do sweeping movements to release subconjunctival fibrosis. If required, we can go under the scleral flap and release the subscleral fibrosis also. You will see the bleb form. It's already starting to form in this video when the subconjunctival fibrosis is being released, and I'm going subscleral to make it flow a little more. And once you've got a good bleb, you turn the needle so that you're far away from the ostium. You don't want the mitomycin or 5-FU, which is more acidic, to flow into the anterior chamber. You stay far away and inject very slowly, hoping that the pH in the AC is not disturbed and the endothelium is not compromised. Mitomycin 0.2 or 0.4, 0.1 ml, or 5-FU 0.1 ml of the preparation that we get commercially, that's 50 mg per ml, can be used as the antimitotic during this process. Ring of steel, this is a concept that everybody has been talking about. You have an area which is exposed with mitomycin with adequate concentration to kill off the dividing fibroblasts. Those areas, all the fibroblasts are gone. But there is an area beyond that where the diffuse mitomycin has got too little concentration to kill them off straight off, and these are going to be dying cells over the next 1 year. For 1 year, you're going to have tissue breakdown products in that area, and this would incite inflammation, then this would incite fibrosis from fibroblasts which is outside of this area, which are fully viable. And so you land up with a vascular bleb like what is shown on top, that one, where it has been walled off so that it can't flow any posteriorly, but we would prefer to have a bleb like what is here, which is a big area and petering off into the periphery. This is ubium, that's a scar tissue there that is stopping the flow. You would prefer to have something petering off like this and going into the periphery. And when that happens, your backward flow is gone, it dissects into the cornea, it can overhang on the cornea. All these are going to cause dysesthesia and visual issues, but also the IOP will also start to go up because the resistance is high. So a ring of steel also can be helped with needling, because you can cut that ring of steel scar with the needle and give the antimitotic. If there's no bleb in an older trap and the ostium is open, consider that there is a scleral flap fibrosis. To look for the ostium, of course, you need gonioscopy. That's a skill any glaucoma specialist cannot avoid. You can needle from outside, like we showed. If you can see or find the edges of the scleral flap, which may be difficult in an older trap, but consider internal re-exploration or even bleb revision. For internal re-exploration, of course, a gonioscopy is a must, because you have to be absolutely sure of where the ostium is. You do a paracentesis, fill the AC with OVD, and use a blunt instrument. Here I use a regular iris spatula. Go through it. You need quite a bit of force, and once you see it subconjunctivally, you know that the bleb is going to form, and bleb forms, and you need to supplement this with the antimitotic as well. If required, once a bleb is formed, it's easier to do a needling to supplement this bleb that is formed. In short, leaks have to be dealt with in the immediate post-op to keep the bleb formed. Massage the bleb up in the early days and wait at least 2 weeks before we do a suturalizis or a release of a suture. Once fibrosis is obvious, go for needling of the bleb, and if there's a subflap fibrosis, we can consider internal re-exploration also. And right through, on gonioscopy, the ostium is blocked, we need to go in and deal with whatever tissue is blocking the ostium. Thank you.
Thank you, Dr. Thomas.